I want to welcome everyone to the OBSSR Director's webinar for November titled Behavioral Pain Management Interventions for Patients with Cancer, Improving Access and Optimization. I'm Christine Hunter. I'm the Deputy Director of the Office of Behavioral and Social Sciences Research at the National Institutes of Health. Before I introduce today's speaker, I'd like to mention a few housekeeping items. First, today's webinar is being recorded, and the recording will be available on the OBSSR website in about 1 month. Today's presentation will be followed by a question and answer session. All phone lines will be muted during the webinar. Questions and comments will not be taken via the phone, but will be taken through the Q&A feature in WebEx. To ask a question or send us a comment, click on Q&A on your screen, select Ask All Panelists, and type in your question, then hit send. My OBSSR colleague, Bill Elwood, will facilitate the question and answer session. Today's speaker is Dr. Tammy Summers, who's an associate professor in the Department of Psychiatry and Behavioral Sciences at Duke University Medical Center and a faculty member at the Duke Cancer Institute. Dr. Summers is a clinical psychologist who has extensive training and experience in the development, testing, and implementation of psychosocial symptom management intervention protocols for patients with cancer and other chronic diseases. Dr. Summers' program of research is in developing efficacious behavioral pain interventions for cancer patients, often using mobile health delivery modalities to improve intervention dissemination and implementation. She is currently the principal investigator on one of the first behavioral intervention symptom management trials to use a sequential multiple assignment randomized trial, or SMART trial. This study is examining doses of a behavioral pain intervention in women with breast cancer and is expected to provide novel information on scaling and personalization of behavioral pain interventions. Thank you so much, Dr. Summers, for presenting to us today. We look forward to your talk.
Great, thank you. Thank you everyone for being on today. So I am talking about behavioral pain management interventions for patients with cancer, and we'll talk through a series of studies that we've done in our group to really try to improve access, and then end with an optimization, or talking about the SMART trial that we're currently conducting. So just to get us all kind of on the same page, we know that pain is one of the most dreaded symptoms in patients that have cancer. Pain can be acute or chronic. Most of what I'll talk about is more of the chronic nature, interventions for pain that last longer than just momentarily or a few days. We know cancer pain can be undertreated, and that many patients experience cancer pain, and that it becomes more prevalent in advanced cancers. There's a number of reasons that patients with cancer might have cancer pain. These may be tumor-related themselves, treatment-related, or they may be medical comorbidities that patients had either prior to their diagnosis or that they have developed during their diagnosis and treatment. When we think about behavioral cancer pain interventions, we are talking about skills-based interventions, and I won't go into, with each study, kind of the details of what we've done. I just want to provide an overview so that you know what I'm talking about as I go through these. So, you know, our intervention components are pain education. So typically we start by telling the patient why we're doing what we're doing and why we think that it matters. We've used the gate control theory of pain often, giving patients a context of why we think thoughts and feelings and behaviors impact their pain. More recently, we have integrated the neuromatrix theory of pain into some of our education pieces of the protocol. And then we provide patients with a number of skills, and for each skill, we give patients a rationale for why we're presenting the skill. We give them instruction in the skill. We do some modeling of the skill, have them practice while they're actually in session with us, and then give them feedback, corrective feedback, so that they may be able to do the skill better when they're at home. And then we make a plan for home practice. And so here you can see this is progressive muscle relaxation. These are handouts that we may give them, and we give them for each skill that kind of go through this series of practice. So why do we care about behavioral cancer pain interventions? Well, there's a lot of evidence that these interventions work for patients with cancer. So there's a number of meta-analysis. This is one of 21 trials in patients with all different kinds of cancers, showing that generally these work, and trials with imagery tend to really seem to work for patients with cancer to reduce their pain. And we do a lot of our work in patients with breast cancer, and so here's a meta-analysis just showing that again, that these seem to work for patients and that patients find some benefit from behavioral cancer pain interventions. So kind of based on this evidence and lots of other evidence, NIH and other agencies really recommend that we enter these behavioral cancer pain interventions into the patient's clinical care. But what we know is there's definitely persistent access challenges. There's barriers for patients to receive these treatments. Kind of if you think overall, a lot of these interventions were developed in a really kind of traditional psychotherapy session. You can think of it as 8 to 12 sessions. They're about an hour long and asking patients to come back into the medical center to receive their treatment. And for patients, there's a number of things that get in the way of this. Just intervention costs. So if you're thinking about 8 to 12 sessions, there's definitely a cost related to that. Transportation availability and cost, so patients are already coming to the medical center for their cancer treatments, so if we want to give them these in-person interventions, we're saying come back again. They are trying to keep up with what they already have going on during treatments, caretaking responsibilities, keeping up with work, so again, time is precious for these patients. And then just the physical and emotional burden of getting into another appointment or the cost of that. And then this last one is thinking about, if you think about yourself, if you had a patient or if you knew someone who needed a behavioral pain intervention, where would you send them? So it's easy to think, oh, I could figure that out. But I think for most of us, if we have to really get on and figure out where to send someone, it can be hard to find someone who's trained to do these interventions widely. So sort of where we started with a lot of this work was that we tried to say, okay, what are the skills that seem to really provide benefit for patients, and can we try to decrease the amount of skills or the amount of information that we're giving patients? And so as we think through most of these interventions today, these are the skills that I'm talking about as I present the interventions that we use in these protocols. So we think that these are probably the skills that are most likely to lead to change for patients. And then there's lots of strategies, so mode of delivery for increasing patient access. People have done a lot of telephone work. We know that this can be very helpful for patients. Video conferencing is another strategy, and I'll talk through a number of these studies. Mobile health, so we've done a little work starting to integrate kind of smartphones, using the video feature on smartphones instead. And then I'll end up with optimization and personalization. So can we try to optimize the intervention? How much do we really need to give people? And can we personalize to what they might actually need based on their characteristics or characteristics of their disease? And I won't talk as much about this, but another way to increase access would be just to implement widely. So when we think about video conferencing, this shows a little bit of, about what we're thinking. So the top picture shows a therapist in their office Skyping with someone, and then the bottom represents kind of the therapist coming into the patient's home. So what we have traditionally done is used iPads with data plans for patients to receive what they would typically receive face-to-face, but to receive it actually in their home. And we've done a series of trials to see if this might work and to see who it works for. And if you start at the top trial here, an early pilot trial we did, which is a single-arm trial, saying, can we provide this intervention to cancer patients at all via iPad and Skype, and then moved on to a two-arm trial, and then sort of did a hybrid. You can see this counterclockwise. And more recently, we've moved into rural settings and are just completing a larger two-arm trial to really try to provide definitive data to say, is this working and how is it working? So common features of the video conferencing studies that I'll talk through are that these have mostly been done, unless otherwise noted, with cancer patients that have stage 1 to 3 cancer. And they have reported a clinical pain score of 3 or greater, so we've really worked to integrate this intervention into their clinical care. So to pull out pain scores from their actual clinical visit rather than to assess them again or in another way. And then the mobile pain coping skills training that they have received in these trials are typically with Skype and iPad in their home, 4 to 6 sessions that are about 45 minutes long. We've used the skills that I highlighted earlier in these interventions, and most of these interventions have had a web-based component. So this is audio or video on a web-based assessment, web-based assessment where they go in either daily or several times a week and provide some sort of score that we can then provide personalized feedback either via the website or the therapist before they Skype with the patient gets the information from their week and can give the patient information that way. So I looked to see when we actually started doing this work, and our first Skype and iPad study was in 2011. So for some of you that may seem like a long time ago, but for others it may not feel like that long. But just to give you some context, if you were using an iPhone, you were using the iPhone 4. If you had an iPad, you were kind of ahead of the curve, so that iPad came out in 2010. The Mini was not around. It came out in 2012. Barack Obama was in his first term at that time. And people often ask why we use Skype instead of another video conferencing app. And the reason that we started with Skype is that Skype could actually, was the only app we could find that could use a data plan at that time, so we didn't want patients to have an internet connection to participate in these studies. So if we would have used FaceTime, they would have had to have an internet connection that would support the streaming of FaceTime. So we started using Skype in these studies because we could use a data plan. Now most of these video conferencing applications will run on data plans. So we set out to see if we could do this. We used 25 patients for this first trial. About half of them were breast cancer patients. The rest were lung, prostate, and colorectal. They had 2 clinical pain scores pulled from their medical records, and the average for the sample was 5.3. These patients were 53 years old, 76% female, and 76% white, and almost half of them reported some comorbid medical disorder. So this is a map of North Carolina just to kind of give you some idea of where the patients were. So you can see Duke is the blue dot there in the middle, and the stars around it represent the patients in this first trial. So we had no criteria about how far away they lived, so we did get a patient that lived a couple blocks away. But on average, patients were 69 or 70 miles away. And these are patients, we were hoping we were getting who we wanted to be getting with this trial, patients that probably weren't going to come back in for a behavioral pain coping skills session, but who had pain and would be likely to benefit from such an intervention. So this first trial, we had good feasibility. Patients completed 3.36 out of 4 sessions. 18 out of the 25 completed all 4 sessions. And 84% of patients completed the trial. So I think for a behavioral trial, we felt good about this 84%, and I think we've improved this percentage of completion over time, just kind of refining what we do with technology and how we're recruiting into the trial to make it meaningful for participants. Again, patients had high acceptability of this initial trial. They said they liked it, they got the information they wanted, they would probably refer a friend, and that it was helpful for their pain management. And this is just a quick graph of the findings. So again, thinking very conservatively about this, this is 21 people pre and post. But generally the take-home message here is that we were seeing improvements in what we hoped to see improvements in. So patients' pain was going down, their physical symptoms like distress and pain catastrophizing were decreasing pre to post intervention. So based on this, we kept moving forward with these trials, not without some technology challenges. So I have people often ask if we lose iPads and that actually hasn't been a big problem. So I would say we've lost maybe 2 to 3% of iPads, and we've probably had 400, slightly over, patients that have taken one home. So we haven't lost a lot of iPads. We don't have people using the data plans, overusing the data plans, and we don't have evidence that they're inappropriately using any of the applications or the internet. We do wipe the iPad completely clean before sending it back out with a new participant. Things that we did have issues with were more mechanical, I would say, with the iPads. So early on, our therapist would be trying to get on for their session, and the patient wouldn't be there, and they would call them on the phone, and they would have them run their finger around the edge of the iPad to actually find the home button. So patients were having a hard time getting it on. So we added a sticker to the home button so that patients would know where to push to get their iPad on. So a number of sort of small things like that, I think, that we've refined over the years to make this easier for patients to use the technology. We wanted to make sure before we moved on to a larger trial with more than just a video condition that we could actually recruit people when they didn't have the video option. So we did, again, a small 2-arm trial looking at mobile pain coping skills training versus an in-person pain coping skills training, and recruited 15 people into both conditions. We had a little more refusal at consent because of this, but it didn't preclude being able to recruit for this study. Our outcomes were similar to what I showed you for the first trial. Patients were generally benefiting in both arms to some degree, a little bit more in the mobile arm. Patients, again, were completing the sessions. But where things got interesting with this is that our days to completion for the people who had the Skype iPad intervention, it was 29.9 days. And so if you think about 4 sessions, this is about 1 a week. This is about what you would want to see. And the in-person sessions, the more traditional sessions, were taking twice that long. And at that point, you sort of get into fidelity issues with the intervention. Are you actually giving people what you're intending to give them? If it's taking that long for people to get it done, when you think about homework or home practice, we're saying, so for the next week, do this. But if we don't see them for 3 weeks, we're sort of not doing exactly what we're hoping to do. So we did see that it seems to take a lot longer in person than the Skype-based. So that was sort of what we had thought with this trial, and then sort of encouraged us again to move on to larger trials with this. One thing that we were interested in with the video conferencing, we have a clinical program in the stem cell transplant clinic, and we provide psychosocial and behavioral symptom management there clinically, and found that we often have trouble. Patients are inpatient a lot of the time. They're not feeling well around transplant. They then go to intensive outpatient, where they've moved to Durham to and stay with a caregiver in an apartment. They come into the hospital daily. They're busy. So we had a lot of time clinically kind of getting an intervention to them, and that made us wonder if there was a way we might use video conferencing to get them an intervention. We knew that several of these patients had pain issues following their transplant. So before we implemented the kind of what we had done before, we did focus groups because we knew these patients had more of a treatment burden. They had been more sick than the other groups that we had implemented the interventions with before. And the thing that we found from focus groups is that the optimal time for these patients might actually be closer to discharge home. So many of them were going home several hours away from the medical center, and they reported that that's when they really felt like they didn't have a lot of support and that they would have more time. So once they returned home. These patients also, in a different way, said, you know, the pleasant activity sounds like a really nice thing, but it's also really important to us to be doing meaningful activities. They talked a lot about volunteering, a lot about spending time with family and friends, a lot of talk of making new relationships. So we implemented that into this intervention as well. And then they also really wanted to tell their stories, and they really wanted to hear other patients' stories, and so that would have been helpful for them to hear around the time they were getting ready to go home. So we also put a lot of advice and stories into the intervention. And then finally, we always have measured the pain in these studies, but the providers actually said, could we also get their fatigue and step measurements daily? So the website, they also put in fatigue and step measurements within this study. So what our final pain coping skills training looked like for these patients who had undergone transplant was one session at the medical center that was in person where they met their therapist, they learned relaxation, and then 5 more sessions once they returned home by video conferencing. We did a small randomized trial with this intervention. So we had the pain coping skills training, the Skype version versus no intervention. Accrual was high. We recruited 90% of what we intended to recruit, and 92% of these patients completed the trial. And of those that started the intervention, they all completed all sessions. I think that actually having kind of this hybrid model where they met their therapist at the medical center was really helpful to get them engaged in the video conferencing once they returned home. And again, we saw the outcomes that we had hoped to see. The pain coping skills group showed slightly greater improvement in pain disability, pain self-efficacy, and fatigue in this study. So we're just completing, to get more definitive answer about this, completing a larger trial. We have recruited 178 patients into this trial. We're almost done. It may come as no surprise, but we're waiting on a few people in the in-person condition to actually finish this trial, and then we'll have all of our post-treatment assessment data. But the questions with this larger pain coping skills versus in-person trial are really around accessibility. Is this feasible? Can we do it? Patient burden. Do patients experience a lot less burden around this intervention if we are giving it to them by Skype? Engagement and acceptability. And then the second aim here is to look at these accessibility variables as mediators of treatment-related outcomes. So hopefully in the next 6 to 8 months we'll have all of that data available. And then the last video conferencing trial that I'll talk about is we talked a lot about who we were actually reaching with these intervention trials. So there's been a lot of advances in mobile health technologies, and we've implemented these at the medical center. And we know that people that get themselves to the medical center at a major academic institution are probably look a little bit different than patients who are receiving their care in medically underserved areas where primary care is lacking, let alone any subspecialty care. So we feel that it's really important to try to get use these mobile health technologies to get to provide even a wider reach for the pain coping skills intervention. So what we have done in the last year is that we've worked to put the pain coping skills via video conferencing into community settings. So we've used 3 rural communities in North Carolina to do this. Again, we used focus groups to kind of make sure we knew what we were doing before we just sort of walked in with iPads and started handing them out. We wanted to make sure that we were doing something that was meaningful to the patients, that the providers thought would be worthwhile. One of the big things we found in these rural hospitals or communities was that there was a lack of behavioral and psychosocial support. Patients used the focus group actually sort of as a support group. They said, wow, it would have been nice to have this during my treatment or afterwards. Patients were enthusiastic about using the mobile health. They were excited about it, but they were also a little bit hesitant. They expressed concerns about whether or not they would be able to connect in their house. Even if they had data plans, they weren't sure that they would be able to use those in their home consistently. So what we ended up doing for the rural communities, we implemented a small single-arm trial, and the intervention for this looked just a little bit different than the other interventions that we've talked about. We adapted the materials for low literacy samples. So we worked with Deb Thorne at the University of Alabama, who has done a lot of work in rural communities with chronic pain, not cancer-related, but really implementing behavioral interventions. And so we adapted our intervention to what she had used before. And if you can see the two slides here, we used a different font than we had been using before. We used put a lot more white space on the pages, and then incorporated a lot of graphics throughout the patient handout. And then the other piece was, because of the hesitancy of handing out the iPad and having patients try to go home and use it, both on our part, we thought that might not work, and then also on our focus group participants' part. We decided to put an iPad kiosk in the community clinic and to have the patient go to their clinic, which is typically 10 to 20 minutes from their home, whereas if they were trying to come to Duke, it would be several hours from their home. And then the therapist was at Duke. So, and then the other piece that we implemented, we wanted to try to approximate what we had been doing in the other intervention trials with the web-based kind of supplement to the intervention. So we put everything that we had typically put on a website on an iPhone for the patients, and many of the pieces of what we put on the iPhone did not require to be connected either to a data plan or to the internet at all times. So this is what the home pages look like for the underserved community intervention. They used messaging as it came. You know, if they didn't have it in their home, we asked them to take it out when they went to the store or when they went to other places where they might connect to the data plans. And we got their pain scores through text messaging. They used cameras to show us where they were practicing their skills. They used videos to also do the same to show us where they're practicing their skills. And then we used Dropbox. So this is very simple applications, but Dropbox to give them videos and audio, and then kind of a session summary that they could listen to in between sessions. So that's what the text messaging looked like, and then here's what the Dropbox files look like for the patient. So in this medically underserved area sample, we looked at 20 participants. Their average age was 58. 75% were African American, 70% married, 50% had a high school degree or less. And if you look at their income here, 35% were reported being under $10,000 income. And so overall, this looks quite different than who we were recruiting from the medical center, which was what we were hoping for, is that we might reach a different population of patients this way who did not have the resources that other patients may have. So this is what it looked like. We didn't have a screen that big, but we had the iPad in the clinic with the therapist in their office. We recruited 20 patients for the study. 18 completed the study, and the 18 also completed all study sessions. They reported that they liked this intervention. And then here's our pre to post intervention changes. So being really conservative, this is 18 pre to post. We have kind of everything laid out there, but maybe the best place to look is the pre to post mean scores. So if you look at pain severity and pain interference, you can see that those are decreasing. And I think maybe the most interesting thing for us was the self-efficacy for pain management. So this is a 10 to 100 point scale. And so patients increased 20 points on the scale from pre to post intervention. And sort of our hypothesis is that they just hadn't been given a lot of kind of behavioral pain, cognitive pain, coping skills, and really benefited. Felt like they had more control over the pain after the intervention. So we hope to do this trial in a larger medically underserved area with more community clinics. So switching gears here a little bit, moving away from the video conferencing, but staying consistent with ways to increase access. We are currently doing a SMART trial that is looking at optimizing the intervention through dosing and personalization. And so what we hope this trial will do is to provide evidence for us on dose response. So the number of sessions is what we're interested in. How many sessions do we actually need to get a response? And then skills. What skills do we need to give participants to get a response? And then we are adapting this intervention within the trial context based on response. So in contrast to maybe a traditional trial where you wait till you get to the last participant through, you pay them, and they're long gone. To see what the outcomes are, what we're looking at is midway through this trial, and I'll show a figure in a moment, are the patients responding? We are re-randomizing them based on response to their next dose of behavioral pain intervention. So this is the full figure of the trial. There's a lot here, and I'll go through it in pieces in a moment. But we are recruiting patients. We're looking for a pain score of 5 at recruitment, and the first randomization is either to pain coping skills, what we call full, which is 5 in-person sessions, or brief, which is 1 in-person session. And then 5 to 8 weeks later, we look at their response. The response assessment we're using is the brief pain inventory, the 4 severity items, and then randomized to their next condition based on what their response is. So if they've responded at 30%, they either get no further intervention or maintenance, and if they have not, they get maintenance or a little bit more pain coping skills training. So just to make sure I've sort of talked through this intervention, we changed directions just a little bit, but the initial doses are in-person sessions, either 5 or 1. A feature of this is that all patients get an MP3 player with relaxation and imagery on it. We were giving out CDs, but found that a lot of people don't have CD players in their house anymore, so kind of shifted the technology that we were using with that. And then all patients get caring text messages for skill practice reminders 3 times a week. And this is a low-cost, automated, easy intervention piece that patients really seem to value. We get a lot of talk in session about those caring text messages, that it was helpful, that it reminded them to practice. And then the secondary doses are in-person and or mobile or landline-based check-ins, caring text messages, and no further intervention. So the first theme of this study is like you would think of a traditional RCT. We're looking at pain coping skills training full versus pain coping skills training brief. And we're just looking at % reduction in pain based on the condition that they were randomized to. And here's the second aim for this study, and this is to provide comparative evidence of intervention dose sequences of pain coping skill that adjust based on dose response or patient response. And so a sequence just is where they went first. So if you look at the top pain coping skills training full, 5 sessions, if they don't respond, they're randomized to the plus. That's one sequence. So there's a number of sequences that patients can go through here, and we're interested in comparing these sequences to see which one leads to the biggest reduction in pain. And so the hypothesis here is that specialized SMART analyses will compare these intervention sequences. This is typically where people start to ask, how many people do you have? How do you do these analyses? We have published a trials paper on this, so it's a little bit more detailed. And I have circled here Marie Davidian and Eric Lauber, who are our SMART analyses gurus at NC State that are really well explain how these analyses will work. And then our third aim of the study starts to move into personalization. So we're really interested in what patient characteristics at baseline will moderate the outcomes at the initial and secondary intervention doses. And so we're looking at pain interference, cancer stage, pain catastrophizing, and race as moderators kind of across the sequences of intervention. And then the last aim here I think is really important and would certainly be missed if we weren't looking at it, is a cost effectiveness aim. So, you know, we're really looking at interventions 1 versus 5 sessions. There's a big cost difference in that. So to look at cost effectiveness, the cost benefit analysis here of, you know, are there people that respond to one session and people that respond to 5? Or you know, are there people that need 7 or 8 sessions? And so hopefully this data will give us a really nice way to look at cost effectiveness. These are the variables that we're using to look at cost benefit analysis with this. Shelby Reed, who's here at Duke, has a nice costing tool that she uses with behavioral interventions that we will use with this trial to look at outcomes in terms of cost effectiveness. We're also looking at accrual, retention, and adherence within this aim as well. So just an idea of how the SMART trial is going. We have, we're about a year and a half in, and we have 111 women recruited out of 327. The average age is 60. 53% are Caucasian, 35% African American, and 12% have reported another race. 51% have a college degree or higher. Their pain scores at recruitment have been 6.26. And about half of the women have had stage 2 breast cancer at recruitment. And then most of the others have been stage 1, so heavy stage 1 or 2 at recruitment. So just a summary and kind of where we're going with this. We think that the behavioral cancer pain interventions, kind of in the way that we're doing this, using hybrid, in-person, mobile, Skype-based, are beneficial in trying to just figure out which work best, which are cost-effective. We also know that there are persistent access barriers to behavioral interventions. So really being mindful of what these barriers are for patients and really thinking about how can we develop and test interventions that might overcome these barriers. So we'll continue to investigate strategies that can increase access. We will use mobile health technologies in diverse settings. We're doing some of that. I've talked about some of that. We also have a trial that we're simultaneously running here in Singapore to see if we can do kind of the same behavioral pain intervention in both settings, and if not, what do we need to change to make it more applicable to different communities. We hope to get a better understanding about appropriate dosing, so who needs one session, who needs 5, who needs maybe 10. We hope that the SMART trial will help us personalize to individuals a little bit better than we do currently. And then we're also doing some work with dissemination and implementation. So, you know, an interest that I have is how much can we actually automate these interventions? Can we push all of this to a pain app to get similar outcomes as those that we're seeing here? So that's kind of where we're going with future directions. This is a non-exhaustive list of collaborators. Obviously, there are many people, many mentors involved in this work. It's definitely been a group effort as we've gone along. That's all I have in terms of presentation. I'm happy to take questions.
Great. Thank you, Dr. Summers. It was very informative and thought-provoking, and I'm going to turn it over to Dr. Bill Elwood to moderate the question and answer.
Okay. Thank you, Dr. Hunter. Did you want to ask a question?
Sure, yeah. So I was struck, I believe in your stem cell pilot focus group and in the rural study, both sets of patients talked about the importance of patient stories, advice, social support, and what your thoughts are about kind of incorporating that in terms of video and mobile technologies. And if, you know, it wasn't listed as one of your key ingredients in intervention, but I'm interested in your thoughts about incorporating social support and patient stories and perspective in future interventions.
Mm-hmm. So we've done a little bit of that. And one of the ways that we've done that, so in the stem cell study, we actually did what we call a controlled social networking page, where we asked specific questions about skills that patients could go into the website and answer. We did moderate that, so we would look at the responses before we made them public to all the participants. And then I think audio and video gives us a lot of opportunity to incorporate patient stories in the network. So in the rural population, we do have an audio on the smartphone for the patients that actually starts with someone saying that she's a grumpy grandma now and she used to be a fun grandma, and it's what we used as an example when we were teaching patients about the smartphone, and you could just see them kind of nod their head and say, yeah, that's exactly how I feel. So I think just kind of more of those kind of opportunities for the social networking for patients to hear other people's stories or experiences. And I guess there's probably a group component here that might be helpful for patients as well.
Absolutely. I think there's some video chat technology that allows for that kind of group component as well, but obviously complicates scheduling.
Yes.
Thank you.
We have thank you. I realize that, your first trial is an R21 and your R01 is current, but do you have any follow-up data on your participants regarding how long they've used the skills they learned from your intervention without electronic assistance?
Mm-hmm. Yeah. So the first follow-up, so the larger, we don't have anything but pre and post at the moment. So the larger trial that we're just finishing, that's the in-person versus video conferencing, we do have immediate outcomes, and then we'll have 3-month outcomes for that. So we'll be able to look at how long they're using the skills.
Oh, great. Back to wireless for a moment. Mm-hmm. Early on, you showed the map only for pilot trial number 1, and yes. I realize it's a small n and with the stem cell therapy, but you also spoke about the medically underserved areas, and I noticed that there are the far west, east near the coast. And then in southern North Carolina, you didn't have any participants, but that was just for that one study. Right. Are there barriers to doing electronic interventions in those underserved areas, or is that just a function of that one small N?
Yeah, that's a great question. So I didn't say that, and I think a really important thing to know with the map is that you could see that patients were kind of all over the state, but like you said, a lot of places that they weren't. And with that population, those are patients that were getting themselves to Duke for treatment somehow, right? So they were not in their community clinics, which there are certainly oncology practices closer to their homes. So I think it's that sample that you saw on the map is biased in that way. So I think getting into the smaller clinics, getting into those rural communities is really important. And there are some barriers, that we see with the rural communities, whereas we're not as confident that they'll have either wireless or the data plans will work in their homes. So we have taken the iPads into the community hospitals or community clinic so that patients can come there and do that. So I think, it may be in 5 years that that's not a barrier, kind of data plans and wireless internet, but my guess is that whatever we're using, there will be people who can't use it in the same capacity as others. So I think that definitely looking for ways to incorporate into those smaller communities better as we go along.
Terrific. Yeah. I realize that the tailoring and the mobile intervention is to bring the intervention to the patient where she or he is and optimize. But we have a question about testing the interventions in a group format. I don't know if you've done that previously, or if you have, or how your work in mobile and remote health compares to group interventions for pain management or mobility among cancer patients.
Right. So, I think that's a great question. It would be great to use the group format. So we've definitely done that in other chronic pain conditions, so arthritis samples, lupus samples, where we've done the group format, and I think that's super helpful. I actually almost believe that in these smaller communities, it might be easier to get people to come in for groups than it would be kind of in an academic medical center where everyone is busy and that it's hard to get in. So, we've thought a little bit about that, is how might we do a group? Could our therapists actually Skype into a group that's together in the community clinic, which would be one way to do that. So yeah, great question. Definitely work to do around thinking about how might we increase social support, which is another question. And I think using groups might be one way to do that.
Oh, thanks for the suggestion about Zoom that came in online. Zoom is a super easy tool for doing online groups.
Okay.
And I also can see how that makes sense for the rural community clinics if you indeed have people coming into the community clinic to use the iPad. You could also take care of some social isolation and have peer support as well. We had another question that came in about whether you've thought about attributing the effect of the intervention due to the relaxation techniques, or is there any effect from an interaction with the clinician who is, only supportive, isn't judging, isn't pitying them? Is there any work that you or anyone else has done separating those two effects, or even questioning them?
No, I mean, I think that's a really nice question. I don't know that. I certainly haven't done work that separates them well. I think one of the, I kind of mentioned at the end, is how far can we automate? And I think an app would be great, and I think we can put all of this into an app, and I'm hoping that we can make that work. But I think that understanding that personalized connection is really important. I'm sure there's people out there doing some of that work, but I think, is a fully automated intervention, pain coping skills intervention versus an in-person intervention, how would those two compare? And I think that's an important question to ask.
How would you described the caring tweets as automated and yet also effective, without obviously giving away anything that is proprietary.
Right.
What kinds of texts what sort of qualities do you attribute to caring texts that are automated and yet obviously seem to be influencing your patients' not only behavior but also their feelings of connectedness to the online therapist?
Yeah. So, I think thinking about, we're calling them caring texts, so they say a little more than please practice your relaxation. We tried to couch them in a way that they feel caring to the patients. They may say things like, you're doing a great job today, take a few minutes to practice relaxation to decrease your pain. So we've tried to put them in kind of a caring context, and I think that the texts are paired with interventions with the therapist, and that their intervention that they're having in person with the therapist is text to that. So we ask them not to respond to the text, but they do respond once in a while. Thank you so much. I practice relaxation. And so we said it's automated. No one's checking this, but they do respond back to that sometimes. So I think, if they were just receiving text alone within the context of some sort of automated intervention, I don't know if they would feel the same about that.
I was really struck in your second pilot trial, the 2-arm pilot trial, and I know it was small, but the difference in days to completion between your mHealth and your traditional arm. And did I hear you correctly that the pain outcomes were similar for those two groups, or I mean, I know that you said there might be some concerns with fidelity, but it seems like it could go either way. That a longer duration of between treatment appointments could mean lots of in between session practice, or it could mean sort of dissipation of engagement in the treatment. And so I know it's small, but do you have any data or hypothesis about the difference in those timelines? It's pretty dramatic and interesting.
Right. It is dramatic. So we do have the data. So that larger trial is just an extension that we have 178 people. So we're waiting on a few people to come through of the in-person condition to look at those outcomes. So the pain outcomes were similar in that smaller trial between those two conditions. So, you could say maybe it doesn't matter how long it takes. But I suspect in the larger trial that we'll see that it does matter, that it's taking a lot longer for patients to get through the trial. We'll also have enough in-person data to perhaps look at people that took 60 days versus those who took 30 days, even, both in person, so be able to answer that a little bit better.
Great. Yeah. So So it looks like there aren't any more questions online, so I think what we'll do is go ahead and close out. Dr. Summers, I really want to thank you for an informative and engaging presentation, and want to let people know that there will be a recording of the webinar that's available in about a month, and also to let you know, everybody online know that there is another webinar scheduled Tuesday, January 23rd. It'll be Dr. Nancy Rediker, and she'll be talking about translating efficacious sleep promotion interventions into clinical and community settings. And so thank you everybody for participating. This concludes today's webinar, and we hope you have a wonderful rest of the day. Thank you.